Right. Good evening, everyone. Thank you for coming to this critical care seminar. Yes. So we shall be starting off our critical care seminar, and today's theme is about sepsis, specifically pharmacotherapy. And we shall have a panel of speakers, each of whom will be telling us briefly about something to do with pharmacotherapy in sepsis. So just a reminder, this will be the outline of what we shall be going through, and thank you for making it to this talk. The other reminder is the AA conference is coming up this month, so you're welcome to register before 7th, before the 8th, to make sure that you have your early registration in. It will be hosted in Ginger, and there'll be lots to learn for the 2 days, plus the pre-conference workshop. All right, so regarding the sepsis pharmacotherapy, we are going to be looking at severely ill patients with rapidly declining physiology, and then we shall look at the morbidity and mortality and cost of care, the impact of altered pharmacokinetics in sepsis patients, and then worrying trends in antimicrobial resistance. We shall have all this part of the discussion, and please feel free to put your questions in the chat for the speakers to be able to respond to them. And in case you want to ask a question live, then please just raise your hand, and then you'll be selected to ask a question live. All right, so the objectives of this, like mentioned earlier, we'll be looking at pharmacology of sepsis, clinical relevance of antimicrobial resistance, how do you make a decision regarding antimicrobial therapy, and then antimicrobial stewardship. So this will be the menu for the talk. We have a wonderful panel of people with interest in this particular topic, as well as trainees who are going to give us the foundational basics. All right, so to start us off, Dr. Stuart Agawa is an anesthesia resident in his final year of training, who is going to give us a clinical case regarding sepsis and pharmacotherapy, and then we shall go into a discussion. We shall give Dr. Stewart about 20 minutes to complete his presentation, after which we shall take about 10 minutes of questions, and then go into the next presenter. Thank you very much. Dr. Stuart Agawa, I hope you will be ready to share your slides shortly. Stuart, are you there? Stuart
Dr.
seems to
Cornell,
be online though.
I'm
Yes,
here.
Stuart, please share your slides.
Okay, thank you.
Stuart, any issues with the slide share?
Yes, doctor. I'm trying to work on it in just a few seconds. Yeah.
Yes, in connect to.
Dr. Cornell,
Yes.
can I send you the document and help me share, because this gadget has failed? Sure.
So let me just a sec. I can share on my side. Do you want to email me your slides?
Yeah, I'm going to send it via WhatsApp right now.
Okay. But who else are you with there?
I'm with Sophie. I'm with
None of the.
Okay.
Are you
Yes.
you're using a laptop? Yes. Please.
Yes, I'm getting.
Ask one of those guys to help you share. Yeah.
Okay, let me do that. Again. State right now. Oh my God! Today is the electricity has caused problems. Nothing connecting. But it's taking long to identify the network.
Stuart, how soon will you be ready?
Dr. Cornell, make me host on the other gadget. I've joined in with another gadget.
Okay, no problem. Okay, you have been made co-host. Stuart, we can see your slides. Please put them in SlideShare and then present a viewer and then start, or whichever you'll be able to show us.
Is it okay now?
Yes, please. You can go to the first slide and please start.
Thank you. Good evening, everyone. Okay, good evening. Sorry for the delay. Had network issues, but I'm now sorted. Can everyone hear me?
Yes, we can hear you. Please proceed.
Dr. Fanel?
We can hear you, Stuart. Please go ahead.
Hello?
We can hear you, Stuart.
Okay, sorry. Thank you so much. I'm going to present a case of that was managed in our ICU. This is a case of MJ, an 87-year-old male who was living in Kawempe, who was managed in our ICU. He presented with sudden loss of consciousness, convulsions, and difficulty in breathing for 1 day. He was an 87-year-old male, non-hypertensive, and with history of a stroke for 5 months with residual left-sided weakness and slurred speech. He was relatively well when he developed loss of consciousness, convulsions, and difficulty in breathing. However, he had no prior history of cough and no history of fever. He was rushed to a nearby health center where his BPs were found to be elevated. We did have this record. It was a verbal report, but we noticed that he was given Lasix and then referred to our unit due to worsening work of breathing. Other systems were unremarkable. He was a non-hypertensive for 5 years and was managed on with amlodipine and losartan, 5 months managed with amlodipine and losartan H, and also had the history of stroke for 5 months with residual left-sided weakness, and he required support for his ambulation and activities of daily living. The recent admission was that when he got a stroke, he had no other comorbidities, no known allergies, and had no any surgical exposure. He was a father of 8, all children alive at the time of history taking. He had a history of alcohol use for 50 years and also was a cigarette smoker. So at EB resus, when he was received, he was sick looking, febrile, he was in respiratory distress with oral secretions, and he had a reduced level of consciousness with a GCS of 11 out of 15. He had elevated blood pressures, and he was saturating at 92 on room air. He was managed as a patient with hypertensive emergency and aspiration pneumonia. He was managed with labetalol, hydrocortisone, glycopyrrolate, and samples were taken off for electrolytes, CBC, and LFTs. However, no specimens at that point were taken off for cultures, and no lactate was done. However, he was started on PISA and metronidazole for the possible aspiration pneumonia. He was also started on anticonvulsants and was given crystalloids. Later, he was transferred to the neuro unit for further management. So at the neuro unit, he spent 2 days there. And while there, he was noted to have AFib, and he was initiated on propranolol and he had worsening respiratory failure, hypotension, and started developing fevers. Then a decision was made to transfer him to ICU for possible advanced respiratory support, hemodynamic support, and neurocritical care support. So on admission into ICU, he was very sick looking, febrile, he had grade 2 edema, and he was in obvious respiratory distress with a non-rebreather mask at 10 liters. He had a temperature of 35.2. His GCS was 11 out of 15, and he had left hemiplegia. Pupils were equal and reactive to light. He was hypotensive with clinical features of hypoperfusion. He had cold peripheries and increased capillary refill time. It was also on non-breather. It was saturating at 85% on room air and had decreased air entry on the left side with widespread scrapers and oral secretions. He also had the catheter in situ that was containing 300 mils of turbid urine. These are the labs that he came with from the research. Notably, he had a low albumin, and liver functions were just, he had elevated GTT, elevated enzymes generally, and the RBS on admission into ICU was 11.1. There was no CPC. The issues at that time were sepsis with septic shock with pulmonary focus. He also had respiratory failure secondary to aspiration pneumonitis. So he had a severe pneumonia, and CAB 65 was equal to 5. The interventions made, he was intubated for airway protection, respiratory and respiratory support. IV access was done, and the urethral catheter was changed. He was mechanically ventilated and sedated with fentanyl and midazolam. He was given a fluid bolus, and samples were taken off. Septic screening was done. Tracheal aspirate, blood, and urine samples were taken for culture and sensitivity. He was also started on Repi to maintain his BPs. His marks are above 65 millimeters of mercury, and other labs that were taken off, samples that were taken off, were CBC, RFTs, electrolytes, and LFTs. However, we didn't have ABG. ABGs couldn't be done. Antimicrobial therapy was also started based on
Stuart, are you there? Hello? Can anyone hear me? Seems we have lost Stuart, or I'm not on.
We can hear you. Stuart is gone.
All right, I guess I'm the one on. Stuart.
Unmute me.
So I think let's give him a moment.
Can use the audio.
Yes, I'm back.
Stuart, we can see your slides. Please, you can go on.
All right. I don't know where I stopped, but he was started on Norepi to maintain his BPs, his maps above 65 millimeters of mercury. Other labs were taken off for CBC, RFTs, electrolytes. However, ABGs were not done. Antimicrobial therapy was started basing on the sensitivity patterns of the unit. Was started on imipenem and imipenem /statin, metronidazole, and fluconazole for possible fungal cover. Other treatments that were initiated included anti-seizure medication, paracetamol for the fevers, and also albumin was started based on the hyperalbuminemia. Then other housekeeping protocols were initiated. So on day 2, these were the issues. He had AFib with rapid ventricular response, had high-grade fevers, and he had copious ETT secretions that were thick and purulent. And he also had increasing vessel pressure requirement. Antiarrhythmic drugs were added. ENT consult was made for tracheostomy placement in anticipation that this patient would take long in the unit, and also for bronchotoileting. Then on day 3, this is the X-ray that was taken in the unit. As you can see, he had bilateral opacities in the lower zones. A picture of a pneumonia. Then on day 3, it was status quo. Rate control had been achieved with the antiarrhythmics, and he had reduced vessel pressure requirements. However, he was still spiking on and off fevers. On day 5, tracheostomy placement was done, and he was noted to have grade 1 decubitus ulcers on both heels and the sacrum. Then culture results were received on day 5. The culture results were received. Only blood culture and tracheoaspirate results were received. The urine cultures were not done. So in the blood cultures, there was staph hemolyticus, which was a possible contaminant, and in the tracheoaspirate, there was Acinetobacter, which was resistant to most of the bugs. However, most of the drugs, sorry. However, it was started on colistin, 9 million units as the loading dose, and then 3 million units Q8 hourly. Then on day 8, the patient's vessel pressure requirements remained relatively constant. He had occasional bradycardias, and antiarrhythmias were adjusted to maintain propranolol and digoxin. He still had fevers and TT secretions, and his vent requirements were constant. He had decreased the gastric absorption and a huge cumulative fluid balance of 8 liters. Plan was to correct electrolytes, start Lasix, aiming at shedding off excess volume, and then albumin was continued to correct the hypoalbuminemia and also improve on the oncotic pressures. So on the right side, we only had electrolytes. These were the electrolyte results that were done on the previous day, on day 7. And as you can see, calcium and albumin were still low. We didn't have a CPC. On day 15, the patient was still very ill. with the low GCS, despite being off sedation. Sedation had been stopped. On day 10, but he remained with a low GCS. His vasopressor requirements were increasing, and he still had he had clinical features of poor perfusion despite the increasing vasopressor requirements. The vent requirements also increased, that was switched to SIMV, and FiO2 requirements increased as well. He had poor absorption, he had hyperglycemia, and reduced urine output with a cumulative fluid balance of 6 liters. So a plan was made to add another vasopressor, repeat cultures. Samples were taken off for tracheoaspirate, tracheoaspirate culture, urine culture, and blood culture as well. Hydrocortisone was also added for possible adrenal insufficiency, and then repeat full hemogram, RFTs and LFTs. Samples were taken off for those. Insulin protocol was started to maintain glycemic control. So labs were received, and he had the only labs that were received were electrolytes, and they had a sodium of 128, potassium of 4. Potassium and chloride were normal. The other extended electrolytes were still reduced, were still low, and he still had hypoalbuminemia. So on day 20, which was his last day in the unit, he had increasing vasopressor requirements with he had refractory shock despite vasopressor, despite increasing vasopressor support. Persistent fevers, and he also had AKI, and he had poor gastric absorption. So on that same day, he suffered a cardiac arrest. CPR was done, and it was unsuccessful. Just to give you, this is a graphical picture of how
Hello, Stuart, are you there? I think we have lost Stuart again. Stuart. Stuart, we don't see you here. I think let's give Stuart a minute. Stuart?
Yes, Dr. Mbaka.
Hello? Okay,
Yes, hello?
so can you please wind up in the next 2 minutes? Wind up your talk in 2 minutes.
Okay, so this is a graphical representation of the temperatures over the time spent in ICU. Then these two graphs show us his urine output, and as you can see over time, the urine output kept on increasing. These spikes that you see because of the Lasix that was being given to try and improve the urine output and also shed off excess volume. But generally, as you can see, his cumulative fluid balance was increasing over time. Then this is a CBC representing white blood cell counts and neutrophils. We only had 4 CBCs done. As you can see, the white cell count and neutrophils over time were reducing. Thank you so much. In summary, I presented a case of an 87-year-old male who presented to our unit from neuro ward with respiratory failure, with secondary to aspiration pneumonia and septic shock. So he was managed for sepsis and aspiration pneumonia, but over time his clinical condition kept on deteriorating until a time when he developed a shock that was refractory to vasopressors. Thank you so much.
All right, thank you very much, Stuart.
Am I on?
Hello, Stuart, are you there?
Yes, Dr. Cornell, I'm there.
Yes. So we have a few questions from the chat room. The first one is, given that PISA does cover anaerobes, what's the role of metronidazole? Is it that PISA doesn't cover suspected GI anaerobes?
Thank you so much. Yes, true. The drug covers anaerobes. However, I don't know why he had to continue with because it was a drug that was prescribed over the time he spent in the ICU. So I cannot tell the reason why they had to maintain. But the drug that was switched to would cover the anaerobes. Thank you.
Okay, maybe the other question is why not use either one of them, and also why use PISA and not maybe another drug like maybe a fourth generation cephalosporin and metronidazole in the initial phase instead of using PISA and metronidazole?
So PISA and metronidazole were initiated from ED resus. And when he was received in the unit, when he was received in the unit, they had to switch to the drug that covers that is sensitive to the bugs that are predominant in the unit.
All right. The other question, my hope is that as we go down the presentations, we are going to get more clarifications on some of the questions that are being asked. So these ones are really related to the case. So the other question that has been asked is, what was the Acinetobacter sensitivity? Stuart, that question is for you.
Acinetobacter was found to be resistant to carbapenems. Well, the sensitivity results that came out showed that it was resistant to most of the drugs on that panel. I think I displayed it on the slide. However, they chose to do colistin as just I think it was the only result they had.
So you're saying the Acinetobacter was carbapenem resistant?
Carbapenem.
Are you saying the Acinetobacter was carbapenem resistant? Stuart? Hello? Is Stuart still there? Sorry, Stuart, we can't hear you in case you're saying anything. Hello, Stuart.
Excuse Dr. Cornell, I would like to say something on top of the same.
Just we need to first clarify from Stuart, but you can go ahead. Hopefully, you'll come back on.
Okay, so if you looked at that sensitivity report which is shared online, the Acinetobacter was resistant to all the drugs which had attempted to, the discs which they had used. Apart from colistin that had an indication of an X, that did not make sense to us really. What did the X mean in the sensitivity pattern? Did it mean either something indeterminate or what? It didn't come clear. But otherwise, it was resistant to all the discs they used.
All right, thank you for that clarification. The other, so how many culture tests were done for this patient? The question here from the chat room is what were the results of the repeat cultures, but we want to know how many culture tests were done during the time that the patient was getting this care.
How do I? Hello?
Yes, Stuart, we can hear you. How many culture tests were done?
So,
and also time difference between them.
So the first culture sample was taken off at the time of admission in ICU, and the result was received on day 5. And
which samples were taken?
The samples tracheoaspirate, blood, and urine. However, results that were received were for blood and tracheoaspirate. Blood indicated Staph hemolyticus, which was most likely a contaminant, and then tracheoaspirate grew Acinetobacter that was resistant to most of the drugs, except for colistin. On the panel, it had an X that really didn't make sense. However, they continued to use. They went on to use colistin.
All right, and that was the only culture.
So the other culture, yes,
okay.
The other culture wasn't received, but the samples were taken off on day 15, but the cultures didn't come out.
Okay, all right. I think that answers the question in the chat room. The other question here: were you using capillary fill time to guide fluid therapy, or just blood pressure and urine output?
Yes, the clinical parameters were being used to guide fluid therapy, that is capillary fill time, and also urine output was also being used as well as one of the clinical parameters for adequate resuscitation.
All right.
Thank you.
The other question is, did you specifically investigate for phangemia?
Pardon?
Did you specifically investigate for phangemia? Phangemia.
The samples that were taken off, we expected to receive as well culture results for fungal, for possible fungal infection. But as earlier noted on the first day of admission, he was instituted on fungal cover with fluconazole. So we thought the culture results would come with the fungal results. Thank you.
Okay. The other question is, did you rule out a PE in this patient?
Pardon?
Did you rule out a PE in this patient?
No, we didn't specifically look out for a PE in this patient.
did you look for any clinical features that would potentially, or even from history that was potentially suggestive of a PE that could explain the symptoms and signs?
I think most of the attention was given to the possible septic shock. So we didn't think that it was. It was more of obstructive shock. So much as clinically the picture was confusing, he had cold peripheries, he had increased capillary fill time, of which in septic shock probably you might have plus or minus warm peripheries. So we didn't specifically.
Was an echo ever done? Was an echo ever done that could have been suggestive?
An echo was not done.
All right. So the final question from the chat room is it possible that staph hemolyticus was not actually a contaminant, given that this was an ICU patient and possibly had devices? Should the patient have received Vanco to cover the gram positives?
Yes, well, it is a possibility. It's a possibility for sure, given that this is an ICU patient, so they can have sepsis from the staph. However, most of the times these coagulase negative staphs are considered are treated as contaminants most of the times.
All right. So maybe I can try and redirect some of the questions to Erasmus if he's online, as I think this is an ICU probably where this patient was, and maybe Erasmus was there and could make some clarifications. So Dr. Erasmus, are you online?
Hey, Cornelia, thank you so much for moderating the team. And Stuart, thank you for your presentation, but I honestly missed most of the presentation. So I am not so sure if I might be of help answering questions related to the case, but maybe just clarification of the thought process of the presenter where necessary.
All right. I think for some of the concerns regarding staph hemolyticus, yes, it's probably a contaminant in this case, and most likely it would be a methicillin sensitive staph aureus. So pulling out the big guns like Vanco may not necessarily be a good idea at this point. And I think the current antibiograms for the ICUs, at least around Uganda, we have less than 20% staph prevalence. So at least methicillin-resistant staph prevalence. So initiating Vanco as one of the first drugs that you want to use to cover up for staph, especially if it's probably a contaminant, may not be the ideal. But also, perhaps sometimes the ICUs can actually tell how the samples were collected and be able to postulate or estimate that the possibility of contamination actually existed during the time of drawing the samples. So unfortunately, Stuart didn't give us any sensitivity patterns for the staph hemolyticus to confirm what kind of profile it had. But maybe that is the sensitivity profile it had was the conclusion, led to the conclusion that it was probably a contaminant and something not to be worried about in the management. Okay, so I hope that the next presenters have noted some of the questions.
Cornel, just a moment.
Yes, Erasmus, go ahead.
Yeah, thank you. I agree entirely with what you say there. I guess the biggest concern, and hopefully in today's talk, maybe just the take home, is that the way we collect specimens for microbiology is compromising diagnostics, especially around things that we easily rule as contaminants. First of all, the technique, then the number of specimens you take. For you to be able to tell that a bug is a contaminant, you probably need to take more than one specimen. Especially blood, if you must pop peripheral as well. And if you grow different bugs, then maybe you can say it's a contaminant. But we most times take off one specimen, really. and the argument is still around cost of care. So it's possible that we actually underestimate some germs and call them contaminants when they are not. And I guess my take, but I agree with you that commonly, it probably would be MSS. I mean, sensitive to to methicillins. Usually, though, if it should be covered and it should not be an issue. But yes, occasionally some patients that can have a resistant type of stuff of the non-aureus stuffs which are also resistant. I guess the comment I want to make is regarding the diagnosis of ruling out a PE, and Stuart can respond here. Not really a comment, but a question. You did say that the patient had warm extremities, cold extremities, among other things, and you thought it was sepsis, not a PE. Given the profound level of shock the patient had, what was the oxygen requirement like in this patient? Dr. Stewart?
Yes, well, this patient's oxygen requirement were high. He was saturating at 85% on a non-rebreather mask with increased work of breathing.
Yeah, so increased work of breathing, were you seeing someone who was just tachypnic breathing very fast, or someone who's breathing fast and using accessory muscles with chest indrawing? Dr. Stewart?
Yes, Dr. Erasmus.
In terms of the work of breathing, was this the kind where the patient is just breathing fast, or was it the patient who is also using accessory muscles with the chest wall indrawing? What was it?
So this patient was using accessory muscles. He also basically was using accessory muscles. So work of breathing was it was tachypnic and as well using accessory muscles. Those were the defining features of his work of breathing.
Okay, thank you. Now, I don't know. Of course, it doesn't rule out a PE. Yeah. It's very easy. Sure. Yeah. It doesn't rule out a PE, but it makes it quite far less likely, because generally you don't really get a patient with a PE developing, poor lung compliance unless you have a massive area of lung infection. Most times patients are just tachypnic, but accessory muscle use is not that significant in them. There's no chest wall indrawing, which is a sign of poor lung compliance area. So clinically, it makes it less likely that the patient has a significant PE, and maybe more for another alternative explanation. So given the patient's background of sepsis, you would wonder if the patient had ARDS or a primary source of infection in the lung with pneumonia affecting his lung compliance. And maybe that's how I would maybe approach that question that was posed to you by Prof. Pauline. Thank you. Dr. Cornelius, over to you.
Oh, sorry. I think I was muted when I spoke. So the next presenter is Dr. Semei, and he's going to tell us about classification and mechanism of antibiotics. Dr. Semei, please share your slides.
I hope I'm audible.
Yes, we can hear you.
Okay. Semei Mtesasar is my name once again. It's an honor to be here. I am just basically going to discuss the antibacterial mechanism of action. In my objectives, we are going to look at the structural differences, especially between the gram-positives and the gram-negative bacteria. We'll look at an overview of the target sites for these antibacterials. We'll look at the cell membrane inhibitors as one of the classification. cell wall protein synthesis inhibitors, and of course, ultimately we'll drill into the DNA synthesis inhibitors. Basic structure, the most simplistic one of the cell wall. I hope we are able to see the picture in front of us. This basically just shows you a very simplistic image of this cell membrane, cell wall inclusive. You have your cytoplasm, you have your plasma membrane, you have a periplasmic space, and you have a peptidoglycan. I hope we're able to see the difference in terms of the thickness of the peptidoglycan, which makes a significant difference between the gram-positive and the gram-negative. And of key to note is the outer membrane that we see in the gram-negatives, which is extremely important, especially if you go into the pathophysiologies of sepsis due to gram-negative bacteria. A little bit of the details. You're able to see the cell membrane, you're able to see the peptidoglycan, but appreciate the difference amongst these things in terms of the thickness, gram-positive versus gram-negative. Then the lipopolysaccharides, which are really classical of the gram-negative bacteria. A few things about an overview of the target sites for the antibiotics. We appreciate that there are multiple sites that we target when we are giving our antibacterials. There are those that will target especially the folate metabolism. That's the cotrimoxazole, not so much in ICU, but more into HIV. We are able to appreciate the ones that we use most, especially the cell wall synthesis, where you're able to see the vancomycin, the penicillin cephalosporins, the monobactam, carbapenems. You're seeing about the quinolones, which target the DNA. There are rifampicins, which so much important in TB, but also sometimes in the staph infections, we tend to employ this. Then partly you see that in the cell membrane, you look at the polymyxins, the colistins of this world, the daptomycins. Then we shall go to the protein synthesis, which is usually inhibited at different levels. We'll drill into the cell membrane inhibitors as earlier on projected by the objectives. Here we are going to drill into the polymyxin and the daptomycin. Basic structure of polymyxin. Commonly in Uganda, we have polymyxin E and the polymyxin B. Classically, these polymyxins, they have a classical structure, which you see that ring-like structure. If you look at figure A, that's the first one up. It's a ring-like structure. This is a polycationic part of the structure of the polymyxin. After that polycationic, you have a polypeptide link in between. Then the last tail is usually a fatty acid tail. So basically, the polymyxin structure is having a lipophilic and a hydrophilic end. So this makes the basis of the mechanism of action. It acts majorly on the cell membrane. Usually what happens, because of the charge that you have, because you have a lipophilic and a a hydrophilic part of the structure of this antimicrobial, that's the polymyxin, you're going to realize that the lipophilic part and the hydrophilic part, they are going to interact at different levels. What you see in figure B is the red part, the red ring with the tail, that is your polymyxin structure. So what is going to happen in your membrane, in your outer membrane especially, you have calcium and magnesium ions as forming part of the components. They'll be the cations. Lipopolysaccharides, by nature of their charge, they are negatively charged. So we know like poles attract and unlike poles repel. So the polycationic part of the polymyxin is going to interact with the negative charge of the lipopolysaccharide. In doing that, you're going to end up with a situation where the membrane permeability, selective permeability of the membrane is going to be interfered with. More to this, as you drill deeper, the lipophilic part of this polymyxin is going to be integrated into the cell membrane itself. So this is further going to cause further this disruption in the permeability, selective permeability of the cell membrane. So as thus, you're going to have, because remember, osmotically, within the cytoplasm, it is much more osmolar compared to the surrounding environment. You're going to have water or fluid entering the cell, as thus you end up with a cell lysis because of the difference in the osmotic potential. Classical differences between the polymyxin E and the polymyxin B is basically in the amine group, in the amino group, but also in preparation. Usually your polymyxin B comes in as a sulfate salt, then your polymyxin E will come in as a sodium salt. I hope we are able to appreciate those few basics. Another drug that falls in the class that interacts with the cell membrane is the daptomycin. This, I have personally not come across daptomycin. Of course, I just have a very few years of experience, but it is one of the very effective antibiotics. How it works, this is a lipopeptide in terms of structure. It has a fatty part and a polypeptide part. So you're seeing that a ring with a tail, that is going to be our daptomycin structure. We appreciate that we said that we have calcium ions within the cell membrane. So what the daptomycin does, because it has a lipo and also a polypeptide side, this lipophilic or the lipo side or the fatty acid side is going to come and interact in a calcium dependent manner with a cell membrane, So once this happens, it's going to cause, as you see on step number 2, it's going to cause oligomerization of this drug. So once these oligomers are formed, it's going to cause depolarization of the cell membrane, as thus, because of the depolarized cell membrane, you're going to have a quick efflux of potassium ions. This alone is going to cause your cell lysis. It's a bactericidal kind of drug, and it is one of those very effective drugs that I used. I hope we are okay as far as that. But because it has interfered with that, to cause depolarization, this ultimately causes the RNA, the DNA, and the protein synthesis to be arrested. It's one of those effective drugs for MRSA. We'll drill into the cell wall inhibitors. Here we are going to look at basically the beta-lactams. Amongst the beta-lactams, you're going to have the basics like the penicillins, cephalosporins with the different generations. You're going to have drugs such as the carbapenems. You're going to have the monobactams. You're going to have the vancomycins of this world. So a quick recap of the cell wall. We appreciate the fact that you have a peptidoglycan layer in the gram-positive that is several layers more than in the gram-negative. So because of that, it makes these drugs have a certain degree of selectivity for gram-positive versus gram-negative. We'll just a quick recap of the cell wall synthesis. During the cell wall synthesis, you're seeing those pentagon-shaped structures in front of you. One has NAM, the other one NAG. These are basically carbohydrate derivatives. One NAM is it's an N-acetylmuramic acid. NAG is N-acetyl-glucosamide. Then what you're seeing as those ring-shaped structures, which are about 4, 5 in terms of number, that's a polypeptide. Those are polypeptide chains. They are made up of a number of amino acids. So during the cell wall synthesis, what happens exactly? You have your carbohydrate derivatives, that's the NAM and the NAG, that are made from the cytoplasm. These ones, because they are made from the cytoplasm, these are linked to the amino acids, the pentapeptides. Those are about 5 molecules of the amino acids. So once these are made a basic structure, these move towards the periplasmic space. I hope we still remember. and they go into a region that we call the cell wall acceptor. So it is in this periplasmic space where you're going to start having the cell wall being laid. It's where the process usually starts to progress from. So you're going to have, under the influence of enzymes such as which form a group, what we call a penicillin binding protein, which is a big group that has several enzymes involved. You're going to have cross-linkage of these peptides so that you form a firm cell wall. So what these drugs do, they just disrupt that entire process. A basic structure of the beta-lactam, we are able to see what you're seeing in red is your beta-lactam ring. You're able to see that the penicillin, the cephalosporin, carbapenems, the monobactams, they all share that structure in common. So it forms the basis of their mechanism of action. The structures down, they just show you what happens when the beta-lactamases come into play. They just usually split this beta-lactam ring, and hence you end up with resistance, or you end up with loss of effectivity of these antibiotics. These drugs, what happens is that I hope we are able to see that the penicillin binding protein, what they do, one of the components within this group of penicillin binding proteins is the transpeptidase. These beta lactams, they inhibit the penicillin binding proteins. Once these are inhibited, you're going to lose the cross-linking of these polypeptide chains. Once this cross-linking is lost, you end up with inhibition of the cell wall synthesis. And because the cell wall, because remember the role of the cell wall is to maintain the integrity of the cell, but also especially in the gram positives, they have a high intracellular osmotic potential. So since they have a high osmotic potential, once the integrity of this cell wall is interfered with, you're going to have osmotic movement of water into this cell, and hence the lysis. We shall proceed. Amongst these drugs, we said we have the penicillins, we have the cephalosporins, we have the monobactams, we have the carbapenems. Classically, usually these drugs are very effective, especially with the gram-positive. But as you go higher, especially say in the cephalosporins, you start seeing gram-negative activity coming in, especially as you go higher into the different generations. If you look at the monobactams, I don't know whether I shared a picture of the monobactams. The difference between it and the rest is that for it, it only has that ring. It only has, I hope we're able to appreciate here, it only has one ring. It doesn't have the other pentagon-like shape like other beta-lactams. It's this monobactam is one of those effective drugs, especially if you're dealing with gram-positives and they are resistant to even the vancomycin. So massive that's resistant to the vancomycin, you could consider a monobactam like azithromycin. So this is another picture to just illustrate this. What you're seeing is a penicillin, just as an example, but carbapenems will have the same mechanism. These monobactams will have the same mechanism. This is just to use penicillin as an example. It just interferes with the cross-linkage of these polypeptide chains. So as thus, it interferes with the integrity of the cell wall, and hence the cell lysis, as you can see on number 4. One of the most important functions, or one of the most important reactions that are important, that help in the cell survival or bacterial survival, is protein synthesis. Some of these proteins will be enzymes, others could be enzymes, could be proteins that help with the bacterial survival. Amongst the drugs that we shall look under this, we'll look at the rifamycin, we shall look at the mupirocin, which is majorly a topical antibiotic, more into gram-positive activity. We look at chloramphenicol, how it works. We look at the aminoglycosides, tetracycline, lazolite, amongst others. We'll start with the rifamycin. Rifamycin is just a group of the antibiotic that what it does, it just inhibits the DNA-dependent RNA polymerase. Within this class, you have drugs such as rifampin or rifampicin, which is one of the commonest that we see in this group. You have drugs such as rifabutin. You have drugs such as rifapentin. Rifapentin, it's used majorly in treatment of latent TB. It's not, personally not seen it, but it's what the beauty with it is that it has a longer half-life compared to the others. We also, I hope, we still remember that rifampicin, unlike rifabutin, is one of the cytochrome P450 inducers. So it's a drug that we have to pay close attention to. It's due to its wide interaction with other medications. So what rifamycin class of drugs does is that it just inhibits the DNA-dependent RNA polymerase. By doing this, remember RNA has subtypes. You have an mRNA, you have that is a messenger RNA, you have a transfer RNA, you have your ribosomal RNA. So once you interfere with the RNA polymerase, it means that you're not going to have RNA. As thus, if you're making a messenger RNA, you're not going to have this protein synthesis process going on. So you're able to see picture A and picture B. In picture A, you're seeing the beta subunit of the DNA-dependent RNA polymerase. Then you're seeing how the process is going on smoothly in figure A. Then in figure B, because of the rifampicin, this is halted. So you're having basically protein synthesis halted at that point. Mupirocin is one of the antibiotics that we use topically on wounds. It's quite sensitive. In vitro, sensitivity seems to be to the gram-positive and the gram-negative. But in vivo, we see more of the gram-positive activity. You look at organisms such as the Staph aureus, things like that. So what this does, it just inhibits during protein synthesis, you remember we have a transfer RNA. The transfer RNA carries an amino acid during the protein synthesis to help in the chain elongation of the polypeptide. So what the mupirocin does, it just interferes with specifically the isoleucine transfer RNA synthetase. So as thus, you cannot be able to transfer isoleucine onto the transfer RNA to further the process of the protein synthesis. So basically, that's how it works. I hope we are able to appreciate the 50S and the 30S, but we shall try to explain it here. Bacterial organisms are prokaryotes, and mammalian, all human beings, we have the eukaryotic kind of cell structures. You have in the prokaryotes, that specifically with the bacteria, you have a 50S and 30S ribosomal subunits, which gives you a ribosome of 70S. Whereas in human beings, you have a 40S and a 60S. So this gives this antimicrobial of this class that level of specificity because of the difference in the subunits of the ribosome. So in the protein synthesis reaction, you have usually you have your 30S. That's the bottom one. You have your 30S. I hope we're able to see the pointer. You have your 30S subunit. It has an mRNA that's attached to it. This mRNA carries codons. Then above it, you're seeing the 50S. The 50S or 50S ribosomal subunit, it has E, P, and A subcomponents within it. A is your attachment point, P is your polypeptide, then E is your requisite. So what these drugs do is just interrupt any of the mechanism of the protein synthesis on this ribosomal structure. So in the process, usually what happens during protein synthesis in these bacteria, it's just the same process like how you see in the human. It's just that in the humans, it's more complex, but it's the same basic steps that they follow. 1, initiation, 2, elongation, then the termination. of the protein synthesis reaction. So what happens is that you have your 30S carrying an mRNA. So this 30S carrying an mRNA, you have to form a complex first. That 50S and the 30S subunits have to come together to form a 70S ribosome. So some drugs will just interfere with this process. For example, oxazolidinones. These specifically examples such as linezolid, they just interfere with the formation of that complex. So by inhibiting that process, that means that you're not going to even to initiate the process of protein synthesis. If we go further to this, you have assuming we form a 70S ribosome. The next step, and we have really formed a very good complex. The next step would be to initiate this entire process, to go on with the initiation. So you're going to have a transfer RNA. Remember your transfer RNA, you're able to see it in blue. It is like hang-shaped in the blue structure at A, that is the attachment point. This transfer RNA is carrying an amino acid, which is colored yellow here in front of you. So this transfer RNA, for it to bind onto, here onto the mRNA for the process to continue, if it is inhibited by drugs such as the tetracycline, the process is going to be halted at that point. We'll proceed to, after that process of the transfer RNA attaching, you're initiating, you have at least one amino acid that has been brought. So the next step is going to be other transfer RNA coming. So other transfer RNA coming, they're going to come at that. Remember, we are at the attachment point. Then we shall go to the P, that's the polypeptide point. You're going to have other transfer RNA coming. So once they've come with their amino acid, this amino acid has to form a bond with the first one that we initiated on the A side. So at that point, we need to have that bond, that covalent bond formed. If this process is inhibited by drugs such as the amphenicals, such as the chloramphenicol, the process is going to be halted at that point. So that is the next step that we have in the protein synthesis. The other step that we are going to go into is the translocation. Remember, we have been forming this polypeptide from the A side of the 50S subunit. So we have to transfer, because remember, this polypeptide, depending on the type of protein that is being synthesized, this polypeptide has to be translocated from A to P for further elongation. So some antibacterial such as the glycosamides, they can inhibit this translocation process because you can't continue with elongation on the A side. Instead, it has to go on to the elongation has to proceed from the P side. Then ultimately, once the chain is done, you'll go into the E side and your protein will be good. So this is another probably a clearer image. We are seeing that tetracycline usually targets the 30S subunit, which you're seeing below. Then the 50S is your bigger subunit. So the tetracycline interferes with the transfer RNA, the first transfer RNA at the A side of the 30S. It just interferes with that process of the transfer RNA binding. Then you have your aminoglycosides. You remember we said that you have codons on the mRNA, then you have anticodons on the transfer RNA. So what the aminoglycosides do is that they just interfere with the pairing of the codon and the anticodons. So if this is interfered with, that means you're not able to be able to read the amino acid that is being carried by the transfer RNA. We talked about chloramphenicol interfering with the transpeptidation, forming those bonds, those peptide bonds between the two amino acids. So what chloramphenicol does is just to interfere with the formation of the bonds between the two different amino acids, one on the different transfer RNA molecules. Something I think more with the macrolides, they just go to interfere with your chain elongation through blocking your translocation pathway. I hope you're able to see what linezolid does. Linezolid, what it does is just to interfere. It's just to interfere with with the formation of the 50S, 30S complex. We'll go
Dr.
into-
Semei, Dr.
Yes.
Semei,
Yes,
I will
please.
give you 2 minutes to wind up your presentation.
There should be enough for me. We'll go into the DNA synthesis. Here we are looking at the fluoroquinol. We know that it's always important for the bacteria to replicate. You need to replicate that genetic material as well. So key enzymes, one, remember this DNA of the bacteria, it is double-stranded and it's attached usually to the cell membrane. So the first enzyme in the process is the helicase that tries to break the hydrogen bonds between the strands that they are separated. Then your DNA polymerase comes in to start the transcription process. So what the fluoroquinolones do is to interfere, because as you're unwinding, you get a region where you have supercoiling, because remember it was initially double strand. So that supercoiling is supposed to be broken, and the enzyme responsible is topoisomerase 2. So the fluoroquinolones just interfere with, they just inhibit topoisomerase 2. Then in the final stages of the DNA synthesis or replication, you have daughter DNA molecules. These ones, to be separated, you need a topoisomerase 4, which is another enzyme that is inhibited by these fluoroquinolones. I hope you're able to see that topoisomerase 3, you have to separate these daughter DNS subunits or components. So it's the enzyme that is inhibited. I think I am done, Dr. Cornell.
All right, thank you very much, Dr. Semei. So we shall check the chat and see if there are any questions. Do you have any questions from the audience? Okay, so Dr. Semei, based on what you have presented to us regarding the mechanisms of action of these drugs and where they work, the patient that Stuart presented was initiated on PISA and metronidazole. What are your thoughts on the combination of these two drugs? Could we not combine them? Should we combine them? Would they work separately? Your thoughts?
My thoughts on this, because PISA is a penicillin that usually targets the gram-positive. Then the metronidazole majorly targets anaerobes. I don't see any evidence of anaerobes here in the patient that was presented. So for me, going with PISA alone could be sufficient based on the presentation without combining with metronidazole. Thank you.
Okay, thank you. I also think, I mean, maybe we can ask the audience in a poll question and see what the audience thinks, and then we can maybe go ahead and discuss it. So I'm going to open up a poll question now. So just hold on. Okay, the poll question has been launched. Please feel free to respond once we hit 50% of the audience, or under 30 seconds, we should be able to close it. Okay, the poll is closed now. We've hit 50%. I will go ahead and share the results of the poll. So we have 63% of the audience saying no, it's not ideal to combine them for suspected aspiration pneumonia. I think it does make a lot of sense. PISA also has anaerobic activity, and so does metronidazole. So combining the two drugs may not yield much benefit. But I think the choice of selection of antibiotics in this patient also depends on how sick they really are. And you may require combination therapy for a patient like this one. But in a scenario where you want to choose between PISA and metronidazole, of course, that also has to be hinged on the risk of multi-drug resistant organisms. So last week we talked about that, including some of the risk factors plus hospitalization, all of which can easily predispose the patient to having multi-drug resistance. And PISA tends to provide you with quite a broad coverage, including anaerobes. And so the addition of metronidazole here may not have added much benefit to the patient. Okay, and then the next poll question is, I'll be checking the chat soon to see if there are any comments, but the next poll question is, therefore, just write down what antibiotics of choice you would have selected, and let's see what the audience thinks. Great. Thank you so much. We shall share the results of those choices with you later. So to go into the chat room and see if there are any questions there. So someone has asked, Thomas is asking, is it safe to avoid carbapenem and cephalosporin for a patient hypersensitive to penicillin in view of possible cross-reactivity? So we shall invite you, Dr. Semay, to respond to that question.
About combining carbapenems and penicillins, I think penicillins, there are certain differences in this structure. If you look at the structure of the penicillin specifically and the
Dr. Semay,
yes.
Sorry, the question is it safe? Yes. Is it safe to avoid carbapenem and cephalosporins for a patient with hypersensitivity to penicillin in view of the possible cross-reactivity?
Okay, can you hear me, doctor? Okay. I think it would really depend on the kind of patient. If a patient needs, to me, from what I've come across, if a patient is allergic to penicillin, it's not 100% that everyone who is allergic to penicillin is allergic to carbapenems. Carbapenems should be able to be used according to what I've come across. Thank you.
Dr. Thomas, do you want to unmute and have a response? Because I'm sure you asked that question, but with an idea in mind.
No, well, I was actually seeking clarification in that regard because then I saw the beta-lactamase ring being discussed. So I noticed that we had a patient probably in ICU who had labeled to have had a reaction to cephalosporin that later was transitioned to meropenem. So I would want to say that it's probably common to see occasionally a patient with a penicillin hypersensitivity, maybe you having concerns of a possible cross-reactivity more so to the cephalosporin. But like he has intimated, it's not something that I think is just typical of all the structure that would cause a hypersensitivity reaction in the other patient who may be taking a carbapenem. Perhaps we use it with a high degree of caution, is what I would really put it at.
Okay. Dr. Erasmus, final thoughts?
Yeah, now regarding the part of for penicillin allergy in the first place, you know, the first thing is, first of all, whether penicillin allergy is real in the first place. So many patients have that label, but actually they're not allergic to penicillin. And in patients who actually react to penicillins, they are reacting to the excipients in the drug rather than penicillin itself. About 95% of patients actually don't have a penicillin allergy. So ideally, anyone who says they have a penicillin allergy needs to see an allergologist. I think that's what the name they call them, the allergy specialist, so that they can actually do testing for an allergy to penicillins. And if they're truly allergic, they can go on to do desensitization. Now, cross reactivity was feared between the two, and we have got an expert pharmacist on the panel. I hope that he can maybe note the question and comment later on. But cross-reactivity between penicillins and cephalosporins doesn't seem to be based on the beta-lactam ring itself, and it's also quite sure. Now, I have not really seen much about the interaction, the cross-reactivity with the other beta-lactam class drugs, particularly cross-reactivity with, say, carbapenems. So I don't think it will be of concern. Regarding the previous question on combination of tazobactam, PISA with metronidazole, you know, maybe just Dr. Cornelius mentioned that we had a talk about the risk factor gram negatives, and maybe tonight for just to recap which ones those are that mean that a patient should ideally get covered with metronidazole on top of other drugs that can cover anaerobes. In this case, I'll just mention quickly that, you know, almost most of the aspiration pneumonias do not need an antibiotic cover. That's the first thing to note. We like to use antibiotics for everything, but most aspiration pneumonias do not need antibiotics. Now, where they need antibiotics, common, depends on the setting. Is the patient who's community-acquired or who has a low risk of hospital-acquired bugs? Simple antibiotics will do it. Now, which patients need an addition of metronidazole? Usually you're looking at somebody who probably has risk of resistant anaerobes, things like Peptostreptococcus, things like B. fragilis, you know, among other things. So for B. frag, you're talking about somebody who has got a perforation of the lower gut. Otherwise, you should probably not be using metronidazole anyhow. For people who got Peptostreptococcus, commonly we're talking about colonization of the stomach in patients who have been on PPIs for a very long time, antacids, that allows the stomach to be colonized by the anaerobic bugs like Peptostreptococcus, among others. Then people who got oral dental hygiene tend to have some resistant anaerobes there too. And of course, if you talk about now the special anaerobes that just need metronidazole, Clostridium difficile, and Fusobacterium, Necrophorium, among others. So these are special conditions that are very rare, and when they happen, you really surely know you need metronidazole. So we abuse metronidazole so much because we think it has got a wide clinical, a wide safety margin. But the truth is that we are seeing a lot of evidence now that metronidazole actually hurts people, especially neurologically. There have been a number of case reports, and you can look them up, of patients undergoing MRI scans after being on metronidazole for a while, but end up with some sort of neurological symptoms. Just look that up. It might help to deter us from the common excitement around using metronidazole. Thank you, Dr. Cornelius. Continue, the team.
Okay, thank you, Dr. Erasmus. At this point, I think I will launch another poll question again, really largely about aspiration pneumonia. So feel free to respond to this one. All right, I think I'll be soon closing the poll. So in case you want to respond, feel free. All right, I'm going to close the poll now. Okay, so as you can see, aspiration pneumonia, which bugs predominate, 80% of the audience picked anaerobes and only 20% picked aerobes. Interestingly, current data actually suggests aerobes predominate and anaerobes are not as common. But like Dr. Rosma said, most times that people have aspiration pneumonia, there's actually really no infection thereafter. And that's why most of the guidelines will recommend you stop antibiotics after 48 hours if there is no sign of infection. So, and when it is there, most times it's going to be aerobes and actually not anaerobes. So next time when you're treating patients with aspiration pneumonia, don't directly jump onto the possibility that it's aerobes, other anaerobes present, but most likely it is aerobes. Sorry about that. Again, I think I was muted. We are going to listen to Dr. Claire Barker, who is an anesthesiologist and a fellow in critical care medicine under the SCALE program. And she's going to tell us about care for patients. She's going to talk about pharmacological nuggets in the care of critically ill patients. So how should we manage critically ill patients with antimicrobial therapy? Is there any difference between them and the other patients that we care for? And how should we tailor our antibiotics to these patients to make sure that we kill the bugs? So Dr. Claire, please share your slides and let's proceed. Dr. Claire, are you there?
Yeah, thank you. Yes, I'm there. Thank you, Dr. Cornell. I'm kindly requesting that you share my slides that I sent in. My network is horrible, so they're likely to I'm likely to keep going off.
Okay, give me a moment.
Good evening, everyone. As Dr. Cornell is uploading the slides, I hope you can all hear me.
Yes, we
Yes,
can.
we can hear you.
Okay. Okay. And thanks for joining in this critical care grand round this evening. I'm going to talk about pharmacological nuggets in the care of critically septic patients. Dr. Semei has given us a bit of what I will share. So I'll probably go off from the mechanism of action of most of the antibiotics. So we'll go straight to basically pharmacokinetics and pharmacodynamics of drugs in septic used in septic patients. So my first slide there, just giving you a brief about the background. So basically in sepsis, we saw that from prior presentations that the pathophysiology involves cellular damage, which is both direct and indirect. And this is basically from release of the cytokines, proteases, reactive oxygen species. But there's also intravascular hypovolemia, which is not just absolute, for which ideally comes from capillary leak and also the disease process, but also the relative one, which comes from vasodilatation. And this initially you have hypovolemia, and as doctors tend to want to correct this hypovolemia, they instead increase the total body fluid, most times even excessively post resuscitation. So we tend to have patients who are fluid overloaded. The other pathophysiological mechanism is impaired microcirculatory blood flow, which leads to heterogeneous organ perfusion, mitochondrial dysfunction, cellular hypoxia, organ dysfunction, and failure eventually. Yeah, so it's important to know that these pathological responses affect or alter the pharmacokinetics of most antimicrobials, but but also the other therapeutic interventions that we use to manage sepsis worsen the pharmacokinetics. For example, inserting chest drains, abdominal drains, putting patients on, connecting them to ECMO, doing plasma exchange, and also renal replacement therapy. So these further alter the antimicrobial pharmacokinetics. It's also very important to notice there's paucity of data of the specific effects of sepsis on drug handling, with most pharmacokinetic studies being performed in healthy volunteers and results extrapolated to clinical practice in a variety of situations. So we don't exactly have enough studies in the critically ill patients. Next slide. Yeah, so looking at drug absorption, we're just going to go through briefly pharmacokinetics in critically ill septic patients. In terms of absorption, we have delayed gastric emptying, that's GI, which is as a result of hypoperfusion, venous congestion, mucosal edema, and also the vasoactive drugs tend to worsen the hypoperfusion, and therefore we have gastric emptying issues, and therefore oral antimicrobials basically cannot be used for patients with sepsis. So this we usually leave this probably in the later stages of recovery. And it's also important to know that since we have poor GI absorption, antimicrobial bioavailability is unreliable. And when it comes to skin and muscle, we have decreased perfusion from the redistribution of blood flow in shock, as you're going to find that you have skin, you have vasoconstriction peripherally, and most of the blood basically is redistributed to important organs. Yeah, and this is compounded by vasopressor drugs. It's also important to notice that while in fever, if you have a patient who has fever, you have vasodilatation peripherally, and so there's going to be increased uptake. And there's been several studies that have been done that show variability of in anti-factor 10A activity after administration of the low molecular weight heparin at doses used for thromboprophylaxis. Moving on to distribution, we all know that the volume of distribution basically just means the total amount of drug in the body divided by its plasma concentration. And for patients who are septic, we have significant increase in volume of distribution of mostly the hydrophilic drugs. And this stems from, so we have capillary leak in sepsis, and also, so this really basically takes all the fluid from intravascular compartment to interstitial, to the interstitium. So we have most of the fluid going to different tissues, and therefore this increases the volume of distribution. But also the other things that increase the volume of distribution, for example, if in hypoalbuminemia, so it means that most of the drugs that are supposed to be bound to albumin are just going to find their way, out of tissues. But also other things like connection to extracorporeal circuits like RRT and ECMO, and also large volumes of fluid given in resuscitation. And also if you have other pre-existing comorbidities which produce ascites and pleural effusions, all these things increase the volume of distribution. And so this means that there's going to be reduced plasma concentrations, and therefore there's a risk of underdosing. And when it comes to some fat-soluble medications, there's instead reduced volume of distribution, again, as a result of this time redistribution of blood away from peripheral tissues into the central compartment, with or without reduction in volume of cardiac output. So if this leads to a higher plasma concentration of these drugs and potential for adverse effects. Next slide. Yeah, so the other factors are the degree of ionization of pKa. So pKa refers to the extent to which the drug can cross membranes. And we have acidemia mostly in sepsis, and weak bases are more ionized at pH values that are below their pKa, which is the opposite for which is the opposite for weak acids. Instead, are going to be ionized at pH values above their pKa. So in sepsis, we're going to have increased degree of ionization of the weak bases, for example, the opioids and local anesthetics, and therefore it means that these drugs are basically going to be mostly unionized, and we have decreased volume of distribution, which leads to the adverse effects. Protein binding is the other factor. There are basically two main drug binding proteins in plasma, and one is albumin and the other is alpha-1 acid glycoprotein. Albumin binds mostly acidic drugs, while the other binds weak bases. And in patients in ICU, we have 40 to 50% of these patients that usually come in with albumin less than 25 grams per liter. So in whenever you have low albumin, this leads to increase in the free fraction of the highly protein-bound drugs with the potential for toxicity. However, hypoalbuminemia itself does not cause significant pharmacokinetic alterations unless if there's also increased volume of distribution and increased clearance. So in such cases, initially you have increased plasma concentration of drugs in low serum albumin, which ideally is going to increase the free fraction of drugs. But if you have now increased volume of distribution and clearance, then the free drug concentration may decrease to subtherapeutic levels. So such drugs may need to be given frequently. So you may need to increase the frequency of administration of drugs that have a high protein binding capacity. Next slide. It's also important to note that midazolam, on the other hand, is extensively bound to albumin with an immediate clinical effect, and so will require reduced dosing. Can you still hear me?
Yes, we can.
Okay.
No slides, but we can hear you.
Okay. Well, I guess I will continue to discuss as Cornell uploads my slides. So the other drug binding protein in plasma we talked about is alpha-1 acid glycoprotein. And next slide, Cornell. And this is an acute phase reactant and is increased in sepsis and other critical illness. So there's going to be increased binding and reduced free drug concentration of the basic protein bound molecules, as we discussed. This binds weak bases. So the clinical effects of drugs, of such drugs, the basic protein binding molecules are is going to be reduced. Yeah, so going to metabolism of drugs. So most drugs are metabolized predominantly in the liver, but there are also other extrahepatic sites that take part in metabolism. It's important to know that clearance of drugs with both high and low hepatic extraction ratio is altered in sepsis. And why the high hepatic extraction ratio, basically these are drugs that depend on high on blood flow to the liver. And remember, in patients who are septic or in septic shock, where we're using drugs like adrenaline, vasopressin, There's patients are on mechanical ventilators, so there's positive pressure ventilation, and all this reduce hepatic blood flow, and therefore the clearance of these drugs with the high extraction ratio. While those with the low hepatic extraction, these really depend on the hepatic enzymatic function, but also in sepsis, there are things that alter the enzymatic function, things like therapeutic hypothermia and also drug interactions. This may reduce enzymatic function and also lead to, so this will lead to reduced clearance of the low hepatic extraction ratio drugs. Next. Yeah, so, and when it comes to elimination, again in sepsis, we have changes in drug clearance. So initially in a patient who is septic, we have augmented renal clearance, which happens about 18 to 40% of septic patients. And it happens really early in sepsis where you have increased renal blood flow associated with a hyperdynamic circulation. And this will affect mostly hydrophilic enzymes, so the hydrophilic molecules. So there is increased clearance of the hydrophilic molecules, and so this so initially you may risk having under your concern will be under dosage of such drugs. So in order to avoid that, what is recommended is you may have to consider high doses of such drugs, and also prolonged or continuous infusions, especially for the beta lactams. And yeah, so with that concern, there's a likelihood that you will have therapeutic failure and also emergence of multi-drug resistance. And later on, when a patient develops AKI in sepsis, we have reduced renal clearance. And in such patients, again, AKI in septic patients is about 30 to 50%. And in these patients, dose adjustments is not really applicable for the first 24 hours. That's like the first and probably a second dose of most drugs, because initially it's the drug concentrations are not really influenced by the degree of drug clearance. Yeah, so it's important to note that various guidance for antimicrobial dose adjustments for those with decreased creatinine clearance is published. This is a huge topic. I can't really exactly go there, but it's important to go and read up on, on dose adjustments in reduced renal clearance. Next slide. So in renal, this RRT is basically renal replacement therapy, and 20% of patients with sepsis end up requiring RRT. And for patients who again, there are different modalities. There's CRRT, we have the prolonged IRRT and IRRT. But it's important to note that there's RRT itself just increases clearance of just hydrophilic antimicrobials, those, especially those with small molecules and low protein binding, the ones available for clearance by RRT. And however, in I beg your pardon. Yeah, so it's important to notice
Claire,
that for patients.
Claire,
Yes.
Hello?
Yes, please.
I'm going to give
Yes,
you 2 minutes to
Cornell.
wrap up. Huh? I'm going to give you 2 minutes
Okay.
to wrap up. Okay.
Okay. So for patients who require IHD, those patients you're going to have to they basically will require additional dosing at the end of the RRT, and it's a bit easier to predict compared to CRRT because antimicrobial clearance is influenced by the type of CRRT itself, but also different antimicrobial properties. So there's a higher risk of subtherapeutic antimicrobial exposure in CRRT, and therefore therapeutic drug monitoring is an ideal option to rationalize antimicrobial dosing. Next, so it's important to understand different antimicrobial agents and their classifications so that you can optimize antimicrobial dosing, that those antimicrobial agents that are time dependent. And basically this means that the antimicrobial activity depends on the percentage time that free plasma concentrations of a drug is maintained above the minimum inhibitory concentration. Then the concentration dependent antimicrobials, the examples right there, which include aminoglycoside, quinolones, metronidazole. These antimicrobial, their activity depends on the peak concentration to MIC ratio. And the concentration and time dependent ones basically depend on the ratio of area under the curve. So it's important that you understand this for optimal antimicrobial dosing. Next. So there are different, so for most patients in the ICU, some may be on ECMO, others require plasma exchange, or others have drains. And it's important that you understand how this alters the pharmacokinetics. So for patients in ECMO, ECMO itself increases both, increases the volume of distribution of both lipophilic and hydrophilic antimicrobials. For the hydrophilic antimicrobials, there's hemodilution in the circuit volume, which really increases their volume of distribution. While the lipophilic ones, it's mostly the drug sequestration within the ECMO circuit. So in patients who are receiving ECMO, usually therapeutic drug monitoring is important so that they can optimize the dosages in these patients. While plasma exchange really is used for management of most autoimmune diseases, for example, TTP and patients who have other maybe acute severe liver injury or liver failure. So what happens is in plasma exchange, since they're taking out plasma, so most drugs with high protein binding capacity tend to go with the plasma itself. So these drugs need to be redosed at the end of the plasma exchange. It's also important to note that patients that have drains, drugs that have a high hydrophilic drugs that have drains increase volume of distribution of these drugs, and therefore such drugs, the studies that have shown that within the drains there were a significant percentage of drugs that were excreted into the drains. So it's important to note that if you have an amount of drainage which is more than 1,000 mL per day, you may need additional dosages of antimicrobials. Next slide.
All right, Claire, I'm sorry, I'm going to stop you there.
Okay.
We need to move to, we have 2 more presentations to make, and I think you have crossed the point where the message is most important for the audience. All right, so I'm going to invite any questions to Claire regarding pharmacological nuggets in critically ill patients. If there are any questions from the audience, please just raise your hand and then you can ask. All right, I don't see any questions. So Claire, my question would be regarding the time-dependent and concentration-dependent and concentration and time-dependent antibiotics. Which ones should we give as infusions and which ones should we give as boluses?
So for time-dependent antimicrobials, you need frequent dosing intervals, and also the length of administration time is important. While for the concentration-dependent ones, it's basically the initial dose and the total like 24-hour dose that is important. I don't know whether that's answered your question.
Not quite. So which one should we give as infusions from that in terms of practicality? How do I take that information to the bedside? So which one should I give as an infusion? Which one should I give as a bolus?
Okay, so for time-dependent antimicrobials, so you basically want to maintain so basically you need a continuous infusion for those patients.
All right. So that means okay. Compared to the concentration dependent.
Yes. Yeah.
So what about the ones? So what about the ones with concentration and time dependent pharmacodynamics? Should we give them as boluses? Should we give them as infusions?
Okay, so sorry, I mixed those up. So concentration time dependent antimicrobials, you just need a higher like initial dose, and then and the whole total 24-hour dose. I don't know whether that.
Okay, so I think because you mentioned time dependent, we give those as infusions, and I think that's appropriate. So things like the beta lactams you mentioned. So oftentimes you're probably going to run maybe an infusion for nearly 1 hour of, let's say, giving meropenem or you're giving piperacillin tazobactam, any of the beta lactam categories. And then if it's aminoglycosides and it's let's say amikacin or gentamicin drugs in that category, then you're saying we shall give those ones as boluses, and that because we just need them to be above the minimum inhibitory concentration. We don't need them to spend time above the minimum inhibitory concentration. We just need them to have to go beyond the minimum inhibitory concentration within the blood. And then for concentration and time, and that would include drugs like vancomycin. Should we give vancomycin as an infusion, for example, or should we give it as a bolus, like the concentration-dependent drugs?
Okay, I think you've answered the question, Cornell.
Yes, there are 3 categories you gave us. So the final one is concentration and time dependent. And one of the examples you said is vancomycin. So it seems to have both characteristics of the time dependent and concentration dependent. So for that one, should we give it as an infusion or should we give it as a bolus?
I think it should be given as a bolus. But again, you also need to keep. So again, you also need to keep like the minimum. So well, I guess such drugs can be given like twice daily, dosing.
Okay. So even for the as long as there is a component of time dependence, the drug needs to be given as an infusion because, like you mentioned, the area under the curve is not just going above the concentration, but the time it will spend above the minimum inhibitory concentration. And so that will give you a much wider area under the curve for a drug like vancomycin. So, and it's not just about the frequency of administration. It's also about the dose itself and how you're actually going to give it. And I think these are some of the principles that we sometimes don't put into consideration, especially when we are treating infections with IVs, and we have to consider that the different antibiotics require a different either concentration or time above the minimum inhibitory concentration to be effective in clearing the organisms. So the other question to you, Claire, would be related to patients who have AKI, for example, and they have, say, non-oliguric, or the oliguric AKI, and they're not on CRT, and you think they have, like this patient, you think the patient has a multi-drug resistant organism. What is your take on us giving an initial massive dose without renodosing? Should we renodose all the drugs even with the initial dose, or should the initial dose be as up to the standard of the requirement?
So mostly the initial dose or even the second doses should really be should not be dosed. However, the doses after those can be dosed.
Okay. I definitely do agree with that. Although some people would say, if you're in a scenario where you have septic shock and it seems like it's profound and the patient is
Dr. Cornelius,
may
you're probably
potentially
muted. We cannot hear you.
Sorry, maybe it's my internet. Can you hear me now?
Yeah, now we can hear you.
No, it wasn't muted. I probably lost connection for a moment. So sometimes, even those with septic shock and AKI, the sequential doses may actually still be high, depending on what you deem the organism to be or what the cultures are telling you, and depending on how critically ill the patient is. Sometimes we may just have to keep the dose as high, just without renodosing it, at least for a couple of days. And the idea there would be you either go big or you go home, because at this point in time, the level of disease or the severity of the disease is overwhelming, and so therefore the antibiotics renodosing them may actually reduce the ability for you to keep above the minimum inhibitory concentration. And so, of course, the other issues that come in that you mentioned regarding renal replacement therapy that may quickly change the concentration of the drug within plasma have to be factored in. So if a patient is on renal replacement therapy, Claire, should we therefore give them the standard dosing, or should we renodose still?
Okay, yeah. So, like I mentioned, so in renal replacement therapy, so most of the hydrophilic drugs are going to be cleared by RRT. So most of these, you're going to require additional dosing at the end of the RRT, as well as also, even if it is CRRT, also they require dosing. So if a patient is on RRT, basically, ideally should not get renal dose. If anything, you need to just give them their full dose at the end of the session.
All right. Okay. So thank you, Claire. And we shall move to the next presenter.
Maybe Dr. Cornelius.
Yes,
sorry.
Dr. Rosman.
Yeah, regarding a part of renal dosing of antibiotics, it's a very important conversation, because every now and again we have a specialist who is not an intensivist walking into the unit and arguing for it, or again, and making quite a scene sometimes. And I guess we need to understand what exactly we're trying to aim at in renal dosing medications. Our goal here is to try to keep drugs at the therapeutic dose in the bloodstream, at the inhibitory concentrations in the bloodstream. And we think that when the patient has got kidney insufficiency to a certain degree, there are drugs that are going to accumulate to higher, possibly toxic levels, or levels beyond which you're not going to gain more benefit. And that's really why you're trying to say, okay, following the kinetics of a drug, you can reduce the concentration. And I think the comment you made, Dr. Cornelius, is quite a big take home for everybody here, that sometimes you have to ask yourself, what is going to be likely to be toxic to the patient? Is it the bug, or is it going to be the antibiotic? For example, if you think about, like say, a patient with gram-negative sepsis and gram-positive sepsis, and you're trying to give them, say, vancomycin for that MRSA or something. The question is, which of the two is likelier to cause AKI to the patient? Remember that many drugs are associated with AKI, not necessarily causing AKI. But also the other thing to remember is that there are drugs that can mimic an AKI picture biochemically without necessarily actually causing AKI. An example is drugs that elevate creatinine because they compete with creatinine for the organic acid importer at the proximal convoluted tubule. So in that case, these drugs by concentration will outcompete creatinine for clearance in the kidney. So the creatinine will be elevated, but the kidney is filtering nicely. It's not injured. We've seen a lot of that with vancomycin as well. There's a lot of fear around vancomycin, but we've seen a lot of it with vancomycin where the creatinine will actually go higher, but the patient's renal function is actually good. And there are studies that actually show that there is no evidence of damage to the kidney using the newer markers of kidney injury. So yes, this drug can cause AKI, but the question is, the poison is not always in the dose. Or more importantly, the poison could be the time. The other drug that is so feared for kidneys is polymyxin B. Again, being an organic acid, there's also a competition for clearance in the kidney, but actually it's more cleared by the liver. So in that case, many doctors would like to renal adjust polymyxin B, but the actual recommendation is to not renal dose it. Since it's cleared by the liver instead, you give it at the full dose because its killing capacity for the bugs is dependent on that. And by killing the bugs, you save the. Thank you.
Okay, thank you very much, Dr. Rasmus. We're trying to make sure that we get all the presenters to chip in so that we get the full spectrum of the sepsis pharmacotherapy. So apologies if I have to stop you along the way. So before we proceed, we are going to go into just probably less than half a minute video to see what happens with drug resistance. And this is something from Harvard that I'm going to share, and then I'll introduce the next speaker. So just pay attention to this.
So what we ended up building was basically a petri dish, except that it's 2 feet by 4 feet. And the way we set it up is that there are 9 bands, and at the base of each of these bands, we put a normal petri dish thick agar.
Just a second. Let me do something to try and.
So what we ended up building was basically a petri dish, except that it's 2 feet by.
Just let me know in case you can hear the video. In case you can't, we shall probably play it at the end.
By 4 feet. And the way we set it up is that there are 9 bands, and at the base of each of these bands, we put a normal petri dish thick agar with different amounts of antibiotic. There's no antibiotic, just in from.
I'm just
So
going to
we
ask
ended up
Dr. Rasmus, can you hear that video on your side?
Yes, I can hear it.
Loud and clear?
Yes, it is.
Okay, then let me proceed. Thank you.
So what we ended up building was basically a petri dish, except that it's 2 feet by 4 feet. And the way we set it up is that there are 9 bands, and at the base of each of these bands, we put a normal petri dish thick agar with different amounts of antibiotic. On the outside, there's no antibiotic. Just in from that, there's barely more than the E. coli can survive. Inside of that, there's 10 times as much, 100 times, and then finally the middle band has 1,000 times as much antibiotic. And then across the top of it, pour some thin agar that bacteria can move around in. The background is black because there's ink in it, and the bacteria appear as white. First, you see they spread in the area where there's no antibiotic, up until the point they can no longer survive. Then a mutant appears on the right. It's resistant to the antibiotic, it spreads, until it starts to compete with other mutants around it. When these mutants hit the next boundary, they too have to pause and develop new mutations to make it into 10 times as much antibiotic. And then you see the different mutants repeat this at 100. And after about 11 days, they finally make it into 1,000 times as much antibiotic as the wild type can survive. And so we can see by this process of accumulating successive mutations that bacteria, which are normally sensitive to an antibiotic, can evolve resistance to extremely high concentrations in a short period of time.
All right. Thank you for listening to that. And I think we shall jump into the next presenter to tell us about. So the next presenter is actually Simon. Dr. Paul Katongole sent Simon to come and tell us about the patterns and mechanism of antimicrobial resistance. So Simon, allow me to invite you to share your slides. I'm going to stop sharing mine so that you can share yours. Thank you very much. And I hope that we can have the previous video as part of the discussion on antimicrobial use and the duration of antimicrobial therapy with the sequential talks. Thank you. I don't think I see Simon online. He was on earlier. I think if Simon is not online, I'm going to invite Daniel Chance, Dr. Mwanda, to present his talk on the dealing with multi-drug resistant bugs and antimicrobial stewardship. So Dr. Mwanda, please feel free to share your slides, and we hope that Simon will be back online shortly.
Thank you so much, Dr. Cornell. I hope I can be heard.
Yes, we can hear you loud and clear.
Yeah, my name is Daniel Chans. I'm a lecturer of pharmacology at Master and KIU. So I'm here to talk about dealing with MDR bugs and AMS aspects. I'm going to be quick because the content is quite much and I don't have a lot of time. So just a brief introduction about me. I'm a pharmacist, a clinical pharmacist, and a lecturer of pharmacology at Master and Kampala International University. So I've been having some few webinars with Dr. Kitutu as one of the people I've been there, and is one of my mentors in this area of antimicrobial resistance and stewardship. So I go straight to talk about what an MDR organism is. I really thought that the person who was supposed to come in before me would have talked about this, but there are different definitions that are given across board. For example, according to WHO, resistance to one agent in 3 or more antibiotic categories. One presenter talked about the different classes of antibiotics. So I believe we know. So if a bacteria is resistant to one agent in 3 or more classes of antibiotics, then it's resistant. And according to the British Society of Antimicrobial Chemotherapy, when they're talking about a multi-drug resistant gram-negative bacteria, they define it as one that is susceptible to 1 or 2 antibiotics, okay? While extensively drug-resistant pathogen is susceptible to 1 or 2 drug classes, according to the European Center for Disease Control and Prevention and the WHO. And then we have what we call pan-drug resistant, which is non-susceptible to all categories of drugs available, okay? So I'll not go back into this, but I was just trying to give different examples. I'm trying to say that these MDR bacteria are sometimes called superbugs. Superbugs because they resist more than 3 categories of antibiotics. And this like E. coli, Klebsiella, Pseudomonas, but we also have some gram-positive that are known to be MDR. And we also have MDR-TB, which is not the focus today. So we have already gone through this classification of antibacterials. I'll not go back there. However, I want to talk about the aware classification of antibiotics according to WHO. I'm hoping that all of us know when we use the word antibiotic and when we use the word antibacterial. Yeah, antibiotic simply means that a chemical is produced by microorganisms, or there are pathways that can kill or inhibit other microorganisms. But we know that many of the antibiotics were got from molds, those are fungi, but some are synthetic or semi-synthetic. So the aware classification talks about the access, watch, and reserve, and this is based on resistance potential. The access should be the first line because they have a low potential to develop resistance. The watch should not be used as first line because they have a higher resistance potential as compared to the access group. And the reserve category is the one that should be reserved for the MDR organisms. Yeah. So in the reserve category, we have 22 antibiotics in that category, where we have the likes of colistin, fosfomycin, linezolid, meropenem, with verbobactam, plasmomycin, polymyxin B among those 22. I'm sure someone talked about the difference between being colonized and being infected. The reason I mention this is that even if someone is colonized, but they do not have signs of the infection, they can still be able to transmit these bugs. Bugs can spread through use of antibiotics and hygiene or infection prevention and control. Then we are likely to spread these bugs. So some of them are in the gut, some of them are in the environment, where they may be harmless until when the patient gets to be exposed to them. So the mechanisms of resistance, someone will talk about them, but of importance is that for an antibiotic to be active, it must reach the target in active form, bind to the target, and alter the function of the target. So if anything happens that the drug does not reach the target, or it's inactivated or pumped out, or the target is modified, we shall have resistance. So for MDR, there are several mechanisms that can lead to this MDR, but if a bacteria has several resistant genes in one bacteria, which has several resistance mechanisms, the mechanisms I'm talking about are the reduced uptake, the efflux pumps, the enzymes, then we shall have MDR, multiple drug resistance. Or if it can be a bacteria having one mechanism for resistance, but that mechanism works for several antibiotics, then we shall have multi-drug resistance. So if there are successive mutations, because remember that these resistance genes can be transmitted either vertically or horizontally. So if there are successive mutations, this can lead to development of multi-drug resistance. Or we have what we call plasmids, which are extra chromosomal DNA, or transposons, which are elements that are used to transmit these genes for resistance. Okay, so I chose to bring about the beta-lactamases, because we know that beta-lactam antibiotics are very commonly used in our setting. Beta-lactamases are enzymes that break down the beta-lactam ring. So there are several of them. There are more than 200 beta-lactamases. And there are two methods to classify them: the Ambler classification, which bases on protein sequences, and it has Ambler class A, B, C, and D, and then the Bush-Jacobi system, which bases on clinical phenotypes. So this is an example of the Ambler class, which goes A, B, C up to D, but I chose only to highlight Ambler class A and B because of time. So, and then the different types of antibiotics that can be substrates of these beta-lactamases, and then how they can be inhibited. Many times we see combinations between beta-lactamases and beta-lactamase inhibitors. And we know that the beta-lactamase inhibitor mainly acts as a suicide inhibitor to inhibit the beta-lactamase, even though some of them may have a slightly weak antibacterial effect. Okay, so I've listed some of them here. Unfortunately for us in our setting, we don't do a lot of research to find out how much of these lactamases are prevalent, so that we can act accordingly. So I talk about carbapinamase. I talk about 4 classes of drugs here in relation to resistance and the mechanisms involved. For example, for carbapinames, we have carbapinamases, which are enzymes that can break down these carbapinames. Like we have what we call carbapiname-resistant enterobacterials. And then we have porin mutations, which is common with Pseudomonas aeruginosa. And then efflux pump upregulation, also common with Pseudomonas aeruginosa. Then quinolones, mutations in the DNA gyrase genes, A and B. And then tigecycline upregulation of a certain gene that efflux. And for 3rd generation cephalosporins, we have mutational depression of AMPC beta-lactamases, as is with Enterobacter. So I'll not go back here. How this what causes resistance? There are several factors that contribute, including overprescribing antibiotics, overuse in animals. We know that we have what we call the One Health approach, which we cannot ignore. Reason being that people are going to consume the chicken, and when we fall sick, you may find that we have already been exposed to these antibiotics. Poor infection control in hospitals, that has been elaborated earlier, and then lack of hygiene, and the fact that we don't have new antibiotics is a big problem, because what is going to happen when all the classes of antibiotics we have developed resistance? Okay, like in the case of pan-drug resistant species, how shall we treat that? That is a question that I pose to all of you. So I think I've talked about this, but I didn't talk about travelers. People who travel. Someone can get an MDR organism, let me say in Kenya, and then that person travels with it to Uganda, and because of poor IPC, then another person can be exposed and then ends up getting the same pathogen, which is already a multi-drug resistant organism. So the consequences of multi-drug resistance, of course, they are hard to treat. You find that the options reduce. As you've seen, WHO has listed 22 antibiotics for this, but as we shall see, not all of them may be indicated. And the higher you go in the antibiotic lineage, the more expensive it is. Sometimes the more toxic the options are. Okay, colistin, for example, is known to be associated with nephrotoxicity. Patients will die, patients will get sick, patients will stay longer in hospitals. And when someone gets an MDRO, if we are trying to talk about antimicrobial stewardship, coming up with actions to reduce the spread and development of antimicrobial resistance, MDR organisms complicates those efforts to reduce antimicrobial resistance. Because the more people get MDR organisms, the more we shall try to seek for higher antibiotics, and then the more the resistance keeps on spreading and the harder it is to treat. And then complications, pneumonias and blood infections that are hard to treat. So I've identified here, this is a real case scenario of a patient who had an infection with Pseudomonas aeruginosa, and then they tested all these antibiotics and they were resistant, including tigecycline, including colistin, including many of the carbapenems, as you can see, and all this was showing resistance. And then my question is, what would you recommend for this patient?
Have we lost Dr. Mwanda?
Okay, so as a clinician, you have to bear this in mind as you're giving this antibiotic. Susceptibility is considered at 8 milligrams per liter, resistance greater than 16. That is minimum inhibitory concentration in Europe, while in the US, less than 16 plus 4 for sensitivity or
I think, can anyone hear me? I think we have lost Dr. Mwanda.
We can hear you.
Dr. Mwanda, we have lost you in case you can hear us.
greater than 128, greater than 28 for
Dr. Mwanda,
prevalences.
Dr. Mwanda.
Yes. Yes.
I'm sorry, we lost you at the point where you said in Europe. Basically,
Okay, so I was talking about differences in breakpoints when it comes to the minimum inhibitory concentration to rule out resistance or sensitivity. And I was saying that if you compare Europe and then CLCI, which we all know, there are different concentrations that are given. For example, for Enterobacteriaceae, piperacillin tazobactam mic is considered sensitive at less than 8 in Europe and less than 16 plus 4 milligrams per liter, according to the CLCI. So I was just trying to say that we might have to come up with our own guidelines where we consider that different pathogens are resistant to certain drugs, because we know that the mic alone is not even enough. Yeah, we know that I'm forgetting her name. Dr. Claire presented, mic is not enough when we are treating resistant bugs. So this tries to highlight a few burdens in the UK scenario. 2012 to 2014, 74% of E. coli and MRSA resistance was from the community. Then 16% was 7 days after hospital admission, 18.4% to Cipro, 10.4% to third generation cephalosporins. So why do I bring out these statistics? I know that we do have a surveillance arm in the National Antimicrobial Resistance Subcommittee, but how often do we get updated with these reports? Because having antibiograms either in the hospitals or a national antibiogram can sometimes help us in choosing therapy, especially empiric therapy, because we know that frequent culture and sensitivity in our setting is not very easy to achieve considering the cost and the time. I'll leave this. I was just trying to talk about high-level bacteria according to the WHO, and you see that many of them are actually carbapenem-resistant bacteria. So therapeutic approaches, we have to in critical patients, especially those with comorbidities, and then treatment should address broad clinical and epidemiological scenarios than just looking at specific multi-drug resistant gram-negative bacteria. I decided to go for the gram-negative bacteria because even when you look at Dr. Semei, who tried to talk about how these drugs act, you saw that the gram-negative bacteria are more notorious for developing resistance, even though we still have the gram-positive. So we should develop guidelines that address local resistance patterns, and then we have to accommodate rapid changes in recommendations. Yeah, that means we have to do frequent surveillance because these resistance patterns change from time to time, and they are not static, considering that there are several mechanisms of resistance, and sometimes patients come into the hospital when they have been exposed to antibiotics. Some studies have shown that patients who have been exposed to antibiotics 4 weeks prior to hospital admission may be at higher risk of developing resistance. So now here we look at treatment guidelines. Of course, I adopted these from the Infectious Disease Society of America, even though I tried to mention what we have in our setting later on, considering the older regimens and the current regimen, okay? So this treatment is based on genes for resistance, yeah? For example, if you look on your left, metallobitalactamases, the recommended treatment is ceftazidime with avibactam together with aztreonam or cefiderocol, which is a newer CD4 cephalosporin that was actually licensed by Food and Drug Administration in 2019. But then if you look at many of these antibiotics I've given here, the guideline is based on evidence. That means they do culture and sensitivity. But like I said earlier, they do local resistance patterns, and then they look at the epidemiology, how much of this resistance happens before they come up with this. And then they also look at which genes are responsible for resistance. For example, if you have a carbapenemase present, it can be a metallobitalactamase that is causing resistance to the carbapenem. It can be a Klebsiella pneumoniae carbapenemase, or it can be an OXA 48 carbapenemase, okay? So, like I said earlier, we do not have enough research done at the molecular level in our setting. I stand to be corrected on that, but as far as I know, we don't have that. So we need to come up with guidelines that are targeted based on what we have in our setting. Okay. So if there's resistance to avibactam, relebactam, or avibactam, these are beta-lactamase inhibitors that are a bit newer, and studies have shown that these newer beta-lactamase inhibitors extend the spectrum of activity of the beta-lactam antibiotic, okay? So I'll not mention them one by one because of time, but I'll tell you that I've listed them later on. So if it's an extended spectrum beta-lactamase, enterobacterial, if it is cystitis, pyelonephritis, or a complicated UTI, then the options are here, nitrofurantoin with trimethoprim sulfamethoxazole, etapinem, meropenem, cilastatin, levofloxacin, and others. Okay, but allow me to go lower to explain a bit more. Again, from the Infectious Disease Society of America, we see antibiotics like meropenem, extended infusion, if someone has an infection outside the urinary tract, and then there's a resistance to etapinem and susceptibility to meropenem. At the same time, when carbapenemase testing results are either not available or negative. So that means we still have a lot to do if we are to tackle these MDR pathogens by trying to do more research based on the enzymes that are responsible for this resistance in the case of the beta-lactam antibiotics. Okay. So if it's a bloodstream infection, a high-dose meropenem infusion is recommended, even if it's a Klebsiella pneumoniae carbapenemase that is causing that is what Dr. Claire presented, that sometimes the concentration is important, but then for some of these antibiotics, the duration of time. So the infusion is going to increase the duration of time that the pathogen is exposed to the antibiotic. Just trying to abbreviate or cefepime. Hello, can I still be heard? Dr. Cornell, can I still be heard?
Yeah, you are breaking up a bit, but we are able to hear a bit of you.
Yeah, sorry, I'm at the AGM here in Imperial Royal, so I just took a side room. Yes, I was saying that for bloodstream infection, based on evidence, high-dose meropenem infusion, which is given as an infusion to increase the duration of time for which the pathogen is exposed to the antibiotic, or piperacillin tazobactam or cefepime de-escalation in non-critical ill patients with extended spectrum beta-lactamase bloodstream infection. Yeah, so de-escalation simply means that initially you can give a drug, but then as you narrow down the spectrum of activity of the pathogen, then you give a targeted antibiotic. If we look at hospital-acquired and ventilator-associated pneumonia, the guidelines of Infectious Disease Association of America recommend individualized hospital antibiograms to prevent unnecessary antibiotic exposure. So I don't know about your setting there in Mulago, whether you have individualized antibiograms, how often you update these resistance patterns, but also the source of the antibiotics and the reagents that you use. So treatment should also depend on the causative MDR pathogen. That is self-explanatory. And then carbapenems, we have extended spectrum beta-lactamase enterobacterial, where we can use meropenem, verbobactam, or ceftazidime, avibactam for carbapenems resistant enterobacterial. We can also use carbapenems, fluoroquinolones, or pseudomonas penicillins like piperacillin tazobactam, rather than pseudomonas cephalosporins like ceftazidime. For MDR Pseudomonas aeruginosa, we can use colistin for MDR Romani. Yeah, so these are important. Of course, like I mentioned earlier, it is important for us to know if a patient is getting a ventilator-associated pneumonia. Number one, what is the most common causative microorganism for that? Number two, which antibiotics are, susceptible or resistant in this scenario, so that we can come up with empiric therapy that is guided based on evidence, but also, like I said, we can do de-escalation as we narrow down the causative microorganism. Complicated UTIs, I may not talk about that. Let me go straight to the complicated intra-abdominal infections. Piperacillin tazobactam are recommended, followed by carbapenem. And research has shown that piperacillin tazobactam is for stable, non-critically ill patients. Otherwise, if a patient is critically ill, because we know that pharmacokinetic parameters change, as Dr. Claire elucidated earlier, ceftolozane, tazobactam, or ceftazidime, avibactam, with metronidazole or meropenem, verbobactam alone are indicated. Remember, these are evidence-based guidelines. Yeah, people don't just get up and recommend these medicines, but they do research and come up with these recommendations. So the main therapies that were used for MDR gram-negative bacteria, the older treatments that anyone would think about include colistin, which is known to be nephrotoxic and neurotoxic, and it must achieve steady state plasma concentrations above 2 milligrams per liter for carbapenemase resistant species. So that is important. So you find that in our setting, again, we don't do a lot of therapeutic drug monitoring, which would help us to know the plasma levels that are therapeutic, but also to monitor toxicity of these agents. Fosfomycin are mainly used in treatment of UTIs. Tigecycline, which is a tetracycline, which may be combined with some other drugs for so many bacteria that are carbapenemase resistant or P. aeruginosa. Aminoglycosides, initially, they were used in polymyxin resistance, but we know that these aminoglycosides, if someone has a respiratory tract infection, they have reduced penetration into the airways. And then piperacillin tazobactam, which is a broad-spectrum antibacterial that covers Pseudomonas. It may be used in critically ill patients with mild or moderate renal failure at a dose of 4.5 milligrams 8 hourly. But this dose may not achieve bactericidal concentration in critically ill patients. As I said earlier, in critically ill patients, different regimen having ceftolozane with tazobactam, ceftazidime with avibactam may be preferred. So the newer treatment options include ceftazidime, avibactam, meropenem, avibactam, ceftolozane with tazobactam, or imipenem with relebactam. Now, it is our role as pharmacists to ensure that these molecules actually get registered on the Ugandan market, but it's also our role to ensure that the knowledge of the prescribers is enriched for them to be aware that these drugs are actually available on our market. Okay, and they are registered in USA by FDA. They are registered in Europe. You can still bring these molecules here, even though they are expensive, but time might reach when they are the only ones that could save our patients here. Cefoperazone with sulbactam, eravacycline, cefiderocol. Obviously, it feels good to read these drugs in textbooks, on the internet, on up-to-date, in guidelines for Infectious Disease Association of America. But at the end of the day, we need to have these molecules available so that we can clinically use them for our patients. So I've listed the drugs and the indications for which they can be given based on what is causing the resistance. Yes. So potential future antibiotics that are still in the pipeline, cefepime, meropenem with nacubactam, cefepime with enmetazobactam. We have bacteriophages.
Dr. Mwanda, I think we have lost you again. I don't know if you can hear us. Hello.
That are also currently class of antibiotics, which are modified.
Dr. Mwanda. I think we have lost him. Perhaps you can give him a few moments to come back.
Hello, Dr. Cornell.
Dr.
Sorry,
Mwanda.
I had a small interruption.
Yes.
With the
We
phone
lost
call
you a
there.
bit. We lost you a bit when you mentioned the phages. We lost you at the phages, I think. Hello, Dr. Manda, are you still there?
Hello?
Dr. Manda, yes, we can hear you. We don't see the screen.
Hello, Dr. Cornell, can I still be heard?
We can hear you, but we don't see the screen. We can hear you loud and clear. Dr. Mwanda, can you hear us? Or can you hear me? And I need talking to myself. I don't know if others can hear me.
We can hear you, Dr. Cornelius.
All right, thank you. Dr. Mwanda, we can't hear you anymore, and we don't see your screen. Maybe as Dr. Mwanda prepares, we could jump. I'm going to launch a poll as it prepares to return, and then he will alert us just to beat the time. So here's a poll question. In septic shock, a patient with high risk of MDR should be empirically covered with how many antimicrobials covering gram-negative organisms? So feel free to respond to that. Dr. Mwanda, are you back? Dr. Mwanda, are you back? Are you there? Okay, we have lost him. So we have about 2 more poll questions to go, and hopefully then Dr. Mwanda will be back, and then he could proceed with the final part of his presentation. So I'm going to close this poll in a few seconds from now. All right, this brings us to the end of that poll, and the results are nearly 90% of the audience says 2. And that agrees with the Surviving Sepsis Campaign guidelines. If a patient is not in septic shock, only 1, but if they're in septic shock and they have high risk, then 2 are recommended. Also, if they're not high risk, if the risk is low for MDROs, only 1 is recommended. There's no time when we recommend more than 2. And then I don't know if Dr. Mwanda is back. Let me just check. He's not yet back. The other poll questions. Okay. I'm going to share them. So the poll question, next one is regarding should we use clindamycin in all MASA sepsis or septic shock? As we wait for Dr. Mana to come back, please feel free to respond to this poll question. Should we use clindamycin in all MASA sepsis or septic shock? And Dr. Rasmus, I'll ask you to respond to this one. I'm going to close the poll in a few seconds. So I'll close it now and then share the results. So the 75% of the audience says no. Dr. Rasmus, any comments? Yeah.
Hey,
Still
Dr.
muted.
Kotel, sorry. Yeah, thank you. Generally, clindamycin has, it's a good drug. It may cover a bit of, it covers MRS and other bugs, but the reality is that clindamycin comes with a number of issues in terms of resistance profile, and it's being broad. Especially means that patients are at risk of other complications, especially including infectious diarrheas like C. diff diarrhea. And yet along the way, there are some relatively better and safer antibiotics in between. So it really shouldn't necessarily be used in all MRSA cases. Most guidelines will put drugs like vancomycin, linezolid ahead of it. Then daptomycin is the other drug that you might want to use for MRSA. But of course, if the patients go to a pulmonary MRSA, you may probably want to avoid it unless there's hematogenous spread, like in a patient with septic embolism, causing the embolize the lung with the MRSA infection. Yeah, that's my response to this. Maybe he might have a different comment.
Okay, thank you very much. I think I do agree with that. There are very few instances when we would actually add clindamycin, and usually that would probably come under the context of when you suspect PVL Staph aureus and you want to deal with some of the toxins that are being released by the Staph aureus. But other than that, it's rarely that we have to use it. And then I'll launch the final poll question. Hope you'll be able to see this. We are not failing to get Dr. Mwanda back. So this will be the final poll question, and then we shall wind up the conversation today. So which of the following drugs should be given as a bolus? And this is based from Dr. Claire's presentation. Which of the following drugs should we give as a bolus? And this is really about concentration dependence and time dependence, as well as concentration and time dependence. So I see Dr. Mwanda is back. We shall give him maybe about 5 minutes tops to wind up the presentation, and then we shall close this session. So Dr. Mwanda, please feel free to share your slides as I end this poll now.
Yeah, I'm sorry,
So
I was affected by bad internet.
Yes,
I'll summarize it quickly.
All right. So let me just share the final poll results.
So I've already gone through this part.
Dr. Mwanda, just a second.
Okay.
So I'm just sharing the final poll results for the audience to see. Of all the drugs here, amikacin is one that we often have to give as a bolus. The rest we usually run as infusions. So Dr. Mwanda, over to you.
Yeah, so let me summarize this by talking about antimicrobial stewardship aspects in this. I have been talking about antibiotics that we can use in MDR organisms, but then when we talk about antimicrobial stewardship and a stewardship program, stewardship means that you're trying to come up with actions to promote the responsible use of antimicrobials. But then the stewardship program means that it's a system-wide health strategy to promote appropriate use of antimicrobials through implementation of evidence-based interventions. So for us to have a stewardship program, it should be evidence-based and not based on what people think. And then we can achieve this through coordinated activities that is involving infection prevention, control. I think I've already defined this. So the goal of stewardship is to ensure that patients get the right drugs. The right drug is given to the right patient, the right time frame for the right duration. And we need to be able to optimize these treatments, because if we don't optimize these treatments, then we are still somehow promoting the irrational use of antimicrobials, which is one of the drivers of antimicrobial resistance. I'll not go back into the drivers of antimicrobial resistance due to time, but even inappropriate administration. If a drug is supposed to be given by intravenous route and then it's given orally, it will not work, because we saw that in certain patient parameters, gastric emptying time is delayed and all that. Of course, diagnosis is one of the key things. If we don't have the adequate test kits available, currently we are challenged that, for example, if you're to do a culture and sensitivity, it can take sometimes even up to a week. And some prescribers don't even trust results from certain labs. So before we make that trusted, then we may be challenged with coming up with evidence-based guidelines. Okay? So at the point of diagnosis, we have to ensure proper diagnosis and proper assessment. At the point of prescription, we have to come up with guidelines and make sure we adhere to them in terms of the choice of drug, the routes, the doses, and the duration. And at the time of dispensing, we have to ensure that adequate instructions are given to patients, drugs are well stored, expired drugs are not given. And then at the point of management has to ensure that drugs are available. We also have to ensure that we do prescription audits, yeah? Because whereas we may choose here and say we have to give vancomycin infusion, but then what are people actually doing out there? So to do a good antimicrobial stewardship program, this evidence must be generated. So these are some of the objectives of antimicrobial stewardship. I will not go into them because of time. But the important principles: one, to improve diagnostics, improve prescribing practices, reduce use of antimicrobials irrationally, including in animals. We have to think of development of new antimicrobials, and then we have to think of improved surveillance. I know we can do this, but also infection prevention and control. I think everyone knows the importance of this, because this is one of the modes by which these resistant bugs spread. So as I wind up, I think I don't have to go back to this. So what can we do at our level? You can improve awareness among healthcare workers by prioritizing antimicrobial resistance, like what you guys are doing right now. If you had frequent webinars to improve the knowledge of prescribers regarding antimicrobial resistance, how it develops, how we can tackle it, that could be very good. Document the prevalence of not only gram-negative, but also gram-negative infection and colonization. What percentage of people are infected? What percentage of people are colonized? Even if it's in an ICU, we may have to have that information. And then we develop guidance on use of these antimicrobials on specific topics. We can look at therapeutic drug monitoring. We can look at empirical treatment. We can look at combination therapy for multi-drug resistance. Not all the time that we have to use a combination of drugs. Sometimes one drug is actually going to be enough. And then we come up with de-escalation protocols based on susceptibility by narrowing down the coverage. Duration of antibiotic therapy is important. And then we also look at PK and PD optimized therapy, which Dr. Claire talked about, okay? We also have to do more research in this this will help inform slightly. So focus on anti-aging primarily, develop antimicrobial stewardship program, apply smart antibiotic dosing, and then review antibiotics daily. The de-escalation we talked about, and then for most therapies, they should stop after 7 days, and this is evidence-based. So I think I should end it at
Dr.
that.
Mwanda?
Yes, I should end it at that.
I'm going to ask you to end there.
Yes,
there's a question for you that I would like you to answer. There's a question in the chat room, and maybe after this we can close. As plans are developed to bring these newer agents to Uganda and make them available here, are there also plans to protect them or limit them? For example, can they only be given after cultures, after the discussion with the microbiologist? That's a question for you.
Dr. Cornell, I lost you.
Oh, sorry. So the question is, you mentioned that there can be plans to bring in the newer antibiotics to Uganda. And the question is, as those plans are being made, are there also plans to protect those antibiotics and limit their use? For example, restricting their use if there's no culture sensitivity, or restricting their use through having a discussion with a microbiologist.
Yes, because remember that I was lucky to have been involved in one of the meetings for coming up with these Uganda clinical guidelines. And some of these drugs, it depends on the level of care at which they are given. For example, if we say they should be given at regional referral, national referral, or special these drugs, because we know that if we don't protect them, there will be a problem. Secondly, obviously, we need a microbiologist to be involved in coming up with these protocols. Why? Because, like I said earlier, looking at MIC or resistance diameters and all that may not be sufficient. Sometimes you may look at it when it is showing that it is resistant outside the body, but then when inside the body, you just need to optimize and play around with the dosing so that you achieve the therapeutic outcome. So the clinician, the microbiologist all have a role to play in coming up with these guidelines, but also protecting them by ensuring who can use them and who cannot use them, and under what circumstances. I don't think that we can use these drugs as first line, but rather after most drugs have failed, so that we can recommend them for our patients. Thank you.
All right, thank you very much, Dr. Mwanda, and I would like to bring this session to a close, and I will take us back to the previous objectives of this talk and elaborate that we set out to look at the pharmacology of sepsis, and I think that has been dealt with adequately. We looked at the clinical relevance of, we haven't had discussion on clinical relevance of antimicrobial resistance, but I think those who attended yesterday's scale grand round, you are able to appreciate that. And then decision-making in antimicrobial therapy and antimicrobial stewardship have been well covered by Dr. Mwanda. So again, why sepsis pharmacotherapy is important is because one, severely physiology are more likely to have different pharmacodynamics and pharmacokinetics for the drugs that we use, and therefore we have to understand the drugs that we're using and the patient that we're giving them to, and how and which bugs we are actually dealing with. And of course, we know that MDROs, whether they are within the ICU or outside the ICU, will increase mortality, they will increase the morbidity and the cost of care to any patient. And therefore, we as healthcare workers need to be very cognizant of the transmission of these MDROs. Most instances, we haven't had the microbiologist, but most instances it's us who carry these bags to the patients. And then, of course, we always have to remember the altered pharmacokinetics and also the pharmacodynamics of the drugs. And then, as we saw yesterday, for those who attended the scale critical care grand round, Dr. Kajumbura clearly showed us the worrying trends in antimicrobial resistance that we are seeing, especially in low and middle income countries. And so it is imperative for us to do the simple things really well, hand washing being number one, and allowing us to avoid transmission to patients. And then, of course, trying to protect the antibiotics we use so that we have a chance to actually be able to battle the multi-drug resistant organisms. So with that, I would like to remind you, I'd like to thank our presenters, Dr. Stewart, Dr. Semei, Dr. Claire, we missed the microbiologist, and then Dr. Daniel Chans Mwanda, who I have to mention, he's also my OB, and I was proud to see him as one of the panel speakers. Thank you very much for giving us your time and presenting this very relevant topic. And thank you so much, audience, for being part of this critical care seminar. Thank you and have a good night.
Thank you. Good night.